Good afternoon, everyone. I'm Amanda Eggen, with the Director of Patient Engagement and Clinical Programs with the RUNX1 Research Program. I'm here today to kick off this webinar featuring this fantastic clinical team from the UK Cancer Genetics Group. This group is a national network that connects specialists across the UK to improve care for people with inherited cancer and blood conditions. The session offers a unique opportunity for the UK RUNX1 community to connect, ask questions, and learn more about NHS care pathways and reproductive options. A couple of housekeeping notes for those of you attending this webinar. As you have questions, feel free to drop them in the Q&A icon or Q&A box. You'll see an icon near the bottom of your screen that you can open up and you can type in questions. The audience will not see those questions. They're frankly anonymous, but there's also a button you can select to hide your name completely from us panelists as well. And at the end, we will turn to your questions and I'll help facilitate that part of the discussion. So now I'd like to quickly introduce one of the five clinicians that are here. Dr. Katie Snape is the chair of the UK Cancer Genetics Group. She also serves as consultant geneticist in hematological medicine at King's College Hospital NHS Foundation Trust and is lead consultant for cancer genetics at St. George's Hospital in London. Dr. Snape works with patients and families to understand and manage inherited risks for cancer and blood disorders. And she's also part-time with Genomics England, helping to bring new genetic discoveries into NHS care. Her background includes a PhD in molecular genetics and many years of teaching and mentoring healthcare professionals about the role of genetics in patient care. I wish I had time to give all of you an introduction. I will let Dr. Snape do the rest of the introductions through the talk. But I wanted to mention Dr. Snape because she pulled us all together and she actually was fantastic and came over to the US about a year ago is when we first met in person for the annual RUNX1 Scientific Conference in Princeton, New Jersey. She traveled here to the US, especially to take part in that meeting and was really interested in how we could all work together, the scientific community, the patient community, clinicians, to best serve individuals with RUNX1-FPD and other disorders, similar disorders. And since then, I've met with her and these fantastic colleagues of hers. Actually, I've met with a couple of you for many years now, but we've met several times and I can see all of you are deeply passionate about optimizing care and well-being for our patient community and family members. So with that, I will hand things over to Dr. Snape.
Thank you so much, Amanda, and it's fantastic for us to be working with you all. And hello, everyone. I probably don't have time to do quite a thorough introduction of my colleagues, but we've got with us Dr. Terri McVeigh, who's another consultant geneticist with a special interest in inherited blood cancers, Dr. Sarah Westbury, who's a consultant hematologist, and then Bev, Speight, and Clair Engelbrecht, who are both genetic counsellors, and who I'm sure will give more intro. We're all going to do a little bit of talking with you, and then we'll have the time at the end for questions. I'm going to start with a little bit of an overview of the kind of national picture of how we deliver care in the UK and particularly what we do in the UK Cancer Genetics Group. So Bev, if you're happy to move on to the next slide for me. So just to explain a little bit about who we are, the UK Cancer Genetics Group. So we're a group of healthcare professionals across clinical genetics and genetic counselling and scientists working in genomic medicine, but also work with our colleagues in oncology or hematology or pathology. And we work with anyone who's interested in improving the care for people who have genetic factors that have increased their risk of developing tumours or a cancer. And we try to look at areas of unmet clinical need and where we can improve access to care pathways across the UK and standardise things by working together to bring people together as a national community to sort of improve care for our patients. Next slide, please, Bev. So in terms of kind of what the activities are that we do, we come and talk to people like we're talking with you today. We also do a lot of work developing guidelines and leaflets. So for a particular gene, what should be the recommended management or care pathway for those individuals. We run national meetings and conferences. So we run meetings where we try and bring people together to agree, okay, this should be the recommended care pathway across the UK. We have conferences where we present the latest information, and then we publish our recommendations for clinical care or guidelines. And in doing so, we collaborate with other national bodies. We work with NHS England on a regular basis. We work with the British Society of Genetic Medicine. We also respond to guidelines from other bodies, such as National Institute for Health and Care Excellence. So we're trying to involve nationally by working collaboratively with colleagues across the community to embed improved care. Next slide, please, Bev. So we began to get interested in inherited blood cancers a little while ago, and a group of us were starting to do clinics that we were increasingly finding people who had genetic changes that increased their chance of developing blood disorders or blood cancers. And so we brought together in 2022 some members from the hematology community, so scientists and people from genetics, so we could try and kind of think about the laboratory pathways where we were diagnosing people with inherited blood disorders, and then how we might think about trying to improve care pathways for people as well. And then we had some outcomes that we published as a result of that, both in routine and then in bone marrow transplantation pathways. And then very recently, Bev led on another national meeting where we looked at some other forms of blood cancers and blood tumours, and tried to bring the community together on those as well. And we'll be publishing on that work very shortly. Bev, next slide, please. So what we have done in RUNX1 in the UK is we try to bring people together, as we've said, through these national meetings, and there was not a consistent viewpoint about what the management and care pathways should be for individuals. And so we did produce some guidelines, but they're still very flexible in terms of how they're interpreted at individual centres. The other big piece of work that has happened is through a body called the National Disease Registration Service of NHS England. And this is a group, and this is their slide, and they have a remit directly from government to drive improvements in population health and patient outcomes by bringing together both genetic information and clinical information along other factors. And next slide, please, Bev. And that begins with a patient journey and then collecting information about diagnoses and making those available in an anonymised way so that we can really drive improvements in research and patient care. And the kind of biggest update in this area is that this group have launched a thing called the National Inherited Cancer Predisposition Register, or the NICPR. And this is for people who have a genetic change in a single gene that increases their chance of developing a tumour or a cancer. And RUNX1 is one of the genes that is on that register. And for the first time, that is enabling us to try and collect data from across the whole country to how many people in the UK have changes in the RUNX1 gene. And at the moment, we're just kind of really trying to centralise that and gather that information. But in the future, what we're hoping is that will really help us to develop new insights and to really understand what's happening in terms of the number of people being diagnosed with conditions as a result of that or not, and helping improve access to research and care pathways. And that only launched in July this year. So I can take questions on any of that afterwards, but I'd now like to hand over to Terri, who's going to talk about a little bit about how we diagnose individuals with RUNX1 in the UK.
Super. Thanks, Katie, and thank you all for joining today. It's such a privilege to be here, and thanks to Amanda and team for the invitation. Next slide, please, Bev. Thank you. So I'm kind of conscious that everybody on the call might be at different stages and have different experience with this disorder and this gene called RUNX1. So I just wanted to make sure we were all talking the same language and all on the same page. And one thing that I think I personally struggle with is knowing what these different cell types are that we keep mentioning when we talk about these disorders. So when you think of disorders affecting the bone marrow, it can either affect all types of blood cells or only certain types of blood cells. So I think if you click on, Bev, you'll highlight some of the cell types that we will mention most frequently. So you can see that, you know, from your kind of parent stem cell, you splinter off into myeloid cells and lymphoid cells. And they do slightly different things. And certain genetic risk factors predispose, I should say, more to myeloid problems than to lymphoid problems, and some to lymphoid problems more than myeloid problems. RUNX1 is typically associated with myeloid problems, but you can get lymphoid problems as well. And a number of you in the audience will probably be familiar with this group of their cell fragments, actually more than cells, but platelets, and that's the main kind of area where we see problems in patients that have RUNX1 alterations. Next slide, please, Bev. So the features of RUNX1 basically depend on which of these cell types or cell fragments are abnormal. And one of the commonest kind of features that we see are problems with these platelets, these little cell fragments. So what your platelets do basically is help in kind of blood clotting and scabbing, not to put too fine a point on it. And people with RUNX1 related issues often find that either they have low platelet counts, or, you know, they might even have normal counts, but the platelets aren't working exactly the way that they're supposed to. So people with this condition would often have issues related to bleeding, and that might go on for several years before they're even diagnosed. If you click on Bev, it'll highlight some of the other features that we see. As Katie has mentioned, we do see some families that actually do have a blood cancer kind of feature, and that does happen in a substantial proportion. So between 1.25% of people with this condition will have some sort of cancer. The majority, as I mentioned, will have these myeloid kind of cell cancers, but we do see the lymphoid ones separately. And a quirky feature of this condition is actually that there are other features that have nothing to do with your blood cells. So we have seen a lot of families where they have skin features, things like eczema. Now, eczema is really common in the general population. So, you know, you can still have eczema and have nothing to do with your underlying genetic disorder as well. But that has been reported in a number of families too. Next slide, please, Bev. So when we think about genetic testing in the genetics clinic, we think about it basically in two broad camps. So diagnostic genetic testing is the testing you do where you haven't established a genetic diagnosis previously. So the kind of traditional way that we used to diagnose something is somebody walks into our clinic, we take a history, we, you know, think we know what's going on, we do a genetic test to try and find the specific genetic change in a family, and then we're able to offer testing to at-risk family members. And when we have identified a genetic diagnosis in a family, the testing that we do in at-risk family members is called predictive testing, because you're trying to figure out who carries the genetic risk factor that puts them at risk of developing a condition. Now, with this kind of RUNX1 issue, we often find that the people we're doing the predictive testing in often already have some sort of feature of the condition. So they're having kind of confirmatory testing to you know, confirm that it is associated with the familial diagnosis. If you click on a little, Bev, the pathway in the diagnostic context for RUNX1 is slightly different than that picture because it's a bit more complicated when it comes to blood disorders. So often we will find that actually we do suspect there's something hereditary going on because there's a family history of a similar condition, and people will start off by doing specific testing, checking for hereditary conditions. And that's how we pick up the RUNX1 alteration. But actually the more common kind of picture is the hematologists, and Sarah will get into this in a bit more detail later. The more common thing is actually the hereditary issue isn't really suspected at all, but it's picked up sort of inadvertently because the hematologists are doing genetic testing on the marrow, trying to figure out the diagnosis in the first place. They spot this little genetic alteration, and actually they figure out that it's a hereditary thing rather than something that has occurred by chance. And if you click on Bev, some of you will have experienced this before, but some of the patients that are having genetic testing will have needed a skin biopsy to try and figure out if it's a hereditary thing or something that has happened in the bone marrow by chance. So many of you may have had the experience of going through the punch biopsy. Generally, when we're doing testing in family members that don't have an established kind of feature of the condition, we can do the testing on blood. So many of you may have had your genetic testing on blood too. But the quirky thing about this is it can be multiple sample types, multiple different ways that this is identified. And that makes managing it very challenging because it may be picked up in the hematology clinic, it may be picked up in a genetics clinic. We're finding some of these things are being picked up by chance because people are having genetic testing for a completely different reason. So they're coming to us from a number of different ways, and those of you on the call may well have had different kind of pathways to come into your diagnosis as well. So Bev, if you click on as well, please. The other thing I wanted to talk to you about is the kind of way that we interpret genetic test results, because often it's not very straightforward, and RUNX1 in particular has been a little bit challenging when we're doing genetic testing. The way I always think about genetic testing myself is, if you think about your genetic information like being the instruction manual that controls how your body grows and develops, genes are like words in that instruction manual, and what we're checking for are spelling mistakes. And I've put up the word here, colour, as an example, because one of the spelling mistakes that we're looking for that are harmful is if, for example, the C was swapped for a T. Like, that's a different word. Is it even a word? It makes no sense. It doesn't do what it's supposed to. That's exactly what we're looking for when we do genetic testing. We want to find these spelling mistakes that change the word in a harmful way, and they're called pathogenic. Okay. Next, please, Bev. What causes us a lot of hassle is if we have more subtle changes. So I call this the kind of Kardashian effect. So if the C is swapped for a K, for example, that still says colour if you say it out loud. And actually, certain changes like that in our genes, we can get away with. You know, they may not be harmful at all. Some of them will be, but we just don't have enough evidence to say that for sure. And those kind of alterations are called variants of uncertain significance. And Bev, if you click on, I think it'll show you how we come to this. So when we're doing genetic testing and we find a spelling mistake, we need to figure out if it's harmful or not. And what we do is we look at different pieces of information. So we look to see, has this been seen in people with platelet disorders before? Has this been seen in the general population? What did the lab experiments show, etc.? And if you have lots of information that all says, actually, this is seen in healthy people, we don't think there's any hassle at all, then actually it's probably not a harmful genetic alteration, and we don't report that out generally. If you click on, Bev will show you the kind of evidence that we look at if we're classifying it in the other. Oh yeah, sorry. This is the VUS situation. So when we don't have an uncertain, or when we have an uncertain result, because we have some information to say that actually it is harmful, but then we have conflicting information to say it isn't harmful. So we'll often have this kind of in between. And sometimes we have alterations that are so unique, we have no evidence in either direction, and that can cause hassle. And in the genetics clinic, it gives us pause for thought, because there are some people that will meet the kind of clinical diagnosis of RUNX1 associated disorder because of their clinical features, even if the genetic test is uncertain. And we sometimes manage them the same way, but may not be able to offer testing to their family members, which is obviously not ideal, because you want to be able to figure out who's at risk in a family. Next slide, please, Bev. Yeah, so that's me chewing on my pencil. The more straightforward results are when you have lots of information to say, look, we've seen this in families with platelet disorders before. The lab experiments say that it's harmful, and it's all very consistent. And that's the kind of result that we, nobody likes being told they have a harmful genetic alteration, but this is a straightforward result to deal with, because we then are able to offer testing to the wider family. Next slide, please. Yeah, so the predictive testing, as I said, and Claire and Bev will explain this in a little bit more detail, but we have 2 copies of the RUNX1 gene, and the reason we have 2 copies is we get 1 copy from our mum and 1 copy from our dad. And if you have been told that one of your copies is altered, so you've got this harmful spelling mistake on 1 copy of your RUNX1 gene, when you're having your kids, you don't know if you've passed on the dodgy copy with the spelling mistake or the normal copy. And the only way that you can figure out if your kids have inherited or not is to do a genetic test to see if they've got this from you. That applies also to siblings, because most of these have been inherited from a parent. So you've probably inherited it from either your mum or your dad, and that means your brother and sisters will need testing as well. And I think I'll hand over to Sarah now, who'll give us a bit more insight into what happens in the hematology clinic. Thank you.
Lovely, thanks Terry, and thanks everyone for coming along today. It's really great to be here. So as Katie said, I'm a hematology consultant. I work in Bristol in the UK, and I look after adults with all sorts of hematological conditions, but my particular area of interest is people with inherited platelet and neutrophil disorders, so conditions like RUNX1 and some of those other similar conditions. And I would just say that I think, following on from what Terry was saying about when we're making diagnoses of RUNX1-FPD in patients in the UK, I think actually those of us that are hematologists rather than cancer clinical geneticists actually see more patients who are diagnosed with this condition who don't have any history of malignancy and don't have any family history of malignancy. So the majority of people that we're seeing are those people who present with an isolated low platelet count or bleeding symptoms, perhaps with or without a family history. And then they have diagnostic testing to look for a genetic cause of their low platelet count or bleeding. And that's how actually in hematology, we're picking up the majority of patients with RUNX1 RUNX1-FPD, and with some of the other sort of related conditions that affect different genes but have some sort of similar kind of clinical features. Bev, would you mind moving on? Thank you very much. So the hematology team input will depend a lot on the particular patient's circumstances and also the hematology team that they are part of and known to. The really key thing is that any patient who has got a diagnosis of RUNX1-FPD should have a named hematologist or named hematology team that is their point of contact for sort of hematology related issues. And obviously, it can be a bit different how patients come into contact with that hematology team. So, for example, those patients who are diagnosed on the basis of being investigated by a hematologist because of a bleeding and platelet disorder kind of question will often get to know their hematology team before the diagnosis is made. Whereas those people who perhaps are identified through family screening that's performed through the clinical genetics team will not meet the hematologist necessarily until after that diagnosis is given. And then there will be plenty of people who perhaps get seen in the hematology clinic because they've got an affected family member and they have testing done in through that route. Or they, of course, may know a hematologist that is in fact a hematologist that treats blood cancers, and they're identified after a blood cancer is diagnosed, and then the kind of steps are taken as Terry's just been describing, and the RUNX1 variant is identified after that. And I think it is a little bit complicated in the UK because actually the RUNX1-FPD sort of patient care is actually mostly driven through haemophilia centres for the majority of patients because of that really quite common for most patients kind of finding of a low platelet count and bleeding risk. And so actually the haemophilia centres, comprehensive haemophilia care centres around the UK are commissioned to look after patients with RUNX1 familial platelet disorder, and that includes actually providing a lot of the counselling that can also be done in the clinical genetics clinic. So there's quite a bit of overlap there in terms of where patients might receive some of their care. So some of that sort of genetic counselling actually might well be delivered through their haemophilia centre rather than through a clinical genetics department. So it does look a little bit different depending on whereabouts in the UK you're living. But one thing that should be common for everybody is that patients should be able to, as I say, access their haematologist. And with that, lots of kind of important features that come as part of that multidisciplinary team around health, education and support. So making sure that they've got the information that they need about the haematological aspects of their condition, what to look out for, what to report, what to get in touch with their haematology team about. And with that, most haemophilia centres work on the basis of having doctors for sure, but yes, also nurse specialists who are an amazing source of support and information for patients with bleeding and platelet disorders. Often input from psychologists or other sort of allied health professionals that perform other parts of the kind of patient support and education role, and really important to have shared care and an understanding of who's responsible for what with the GP team as well. Obviously, we are very keen to make sure that any sort of bleeding symptoms or risks are identified and managed. So that's really important for people who are experiencing day-to-day bleeding, but also if you think about it in the setting of needing input for, say, an operation or a procedure, or because these things can crop up, or that a medication has been recommended for you that might increase your risk of bleeding. And so having input for the sort of bleeding side of things is obviously a really key component of it for all patients. The kind of components about it that's more malignancy related will depend a lot more on individual family circumstances and patient circumstances. And we know that there's not currently a kind of UK agreement or guideline about what's the best form of monitoring in terms of things like blood count or bone marrow findings, or whether in fact even patients need to have a bone marrow performed if they're diagnosed with RUNX1-FPD. That's not taken as necessary by all haematologists across the UK. So there is a lot of variability there in terms of what might be recommended on that front. But I think what I would say is that the role of haematologists then comes back to being that sort of education and support and open access. Because what we really want patients to feel is that they know what kind of things they should be looking for, what kind of health problems that if they start to get any worries, they should report to us promptly. and have a really clear way of getting back in touch with people quickly, so that if they have got any concerns, we can look into that immediately and make sure that patients are getting the right advice and next steps. So that's a really brief overview, but we may well end up picking up some of this again, perhaps at the end, but I will pass over now, I think, to Bev for her next bit.
Thank you, Sarah, and thank you to the RUNX1 research programme for inviting me to be part of this. I'm Bev Speight, I'm a genetic counsellor. I'm going to talk a bit about what happens after a referral to the genetics service and in a genetics clinic. So I'm speaking out of the genetics service I work at, which is in Cambridge, part of the East Anglian Medical Genetics Service. But actually there are 20 which cover the whole of the UK. They're listed here in tiny red dots on the map, and I took these images from the British Society of Genomic Medicine website. So essentially, genetic services work regionally, and there is a genetic service that covers all parts of the UK. In terms of the work that we do, so genetic services get referrals in from multiple different specialties, including primary care. So a lot of our referrals are from GPs, but we also get referrals from hematology, and that's for people of all ages. So very young children, older children and adults of all ages. We usually look into a bit of background once we get a referral, and genetic services are very interested in family history. So I think it's fair to say for most genetic services that we try and obtain quite detailed family history before seeing someone. Sometimes that's something that we still need to look into and record in the clinic appointment. We see people in outpatients appointment in the genetics clinic. And that might be an appointment in the hospital that the service runs out of, or one of the regional hospitals in the broader region that that genetics service serves. And it might be a face-to-face appointment, it might be a video appointment, or sometimes a telephone appointment. So there are different ways of having an appointment with the genetic service. And the point of that is to try and individualise discussion about the reason for referrals. So thinking about, you know, how long has the information about RUNX1 come about in the family? What are that person or family members' questions? What we do in the genetics clinic is talk a lot about risk in different ways. So it might be risk of the person in that family who's come forward, thinking about what's the risk that they have inherited a known familial RUNX1 gene variant, or it might be that somebody has had testing already, is being seen in the genetics service and wants to know more about their risk of developing associated problems. And we talk about options around the genetic testing that may be still an option for them if they've not already had that done. As Sarah mentioned, there is some of these conversations and tests will happen in hematology services. We do a lot of facilitating decision making about the different tests available, the implications in terms of psychosocial consequences for that person, and the knock-on effect in terms of family members and the knock-on impact on the risk for family members. And so I'm a genetic counsellor. Sometimes people who come to a genetics clinic might see a genetic counsellor, or they might see a genetics doctor. Genetic counsellors are not therapeutic counsellors, but we are doing supportive discussions around these issues that come up. And we're also helping people to inform their family members and help people identify who might need to know and how might that information be shared in the best way. Something that does come up in the genetics clinic, which is relevant for RUNX1, is talking to children. And that might be thinking about at what age should a RUNX1 predictive test be offered, or it might be later on, whether or not a child's had a genetic test, just in terms of introducing the familial condition and talking about that at home in an age-appropriate way. We've been getting together as a group to try and do some of the things as part of the UK Cancer Genetics group that Katie introduced. One of the things we realised a couple of years ago was that we didn't have any patient-specific leaflets. So we've this is just an excerpt of the RUNX1 leaflet that we've got on the UK Cancer Genetics website. And this is the bottom of that. There are 2 pages in this leaflet, and we tried to put in there it's not individual information for patient and family, but it's just general information that's freely available on the website and covers some of the things that are relevant. We've had hematologists, clinical geneticists, patient representatives, and some charities have a look at these and provide input, as well as a patient and public group in terms of the wording. So we're grateful to the RUNX1 research programme for having a look over those and just helping us finalise them, and they will be up for review soon. And then lastly, this is my last slide. So this is just an excerpt from the current RUNX1 UK management guidelines, which are also on the UKCGG website. We've split them into sections in terms of surveillance, which, as Sarah's already mentioned, isn't something that we've got as standard in the UK. It's really based on individualised information about platelet counts, etc. There are other pieces of this information, and this is just one part of the guideline that we've published. In terms of the bottom box, so family matters, that is something that we would address in a clinical genetics appointment, with that some overlap with the hematologists. I've already mentioned the age at which predictive testing should be offered often comes up, and the other thing might be people who haven't completed their families yet, or even started their families, and they might have questions about the inheritance of this and possibly have concerns about passing it on. So that would be something that we would address in the genetics clinic. And at this point on that topic, I'm going to hand over to my genetic counsellor colleague Claire, who's going to say a bit more about that.
Thanks, Bev. Hi, everybody. Thank you so much for having me. So I'm Clair Engelbrecht. I'm a genetic counsellor. So I work both within the hematology team at one of the tertiary hospitals in London, where I counsel patients that have confirmed or at risk of inherited predispositions to hematological malignancies, including RUNX1. I also work in a fertility clinic, so I speak a lot about family planning options. So I'm going to speak to you a little bit about that today. Next slide, please. So Terry's already gone over this. Thank you, Terry. So the inheritance pattern of RUNX1, familial platelet disorder, is autosomal dominant. So when a person has the condition themselves, there is a 50% chance that they can pass it on to all their children. Next slide, please. So what options are available to young adults who want to expand their family or haven't yet started their family? So there are a number of options we discuss in the genetics clinic. So it could be that you decide to get pregnant. That could either be naturally or via assisted conception, and do nothing. Do no further testing in the pregnancy outside of routine pregnancy screening. And then any children that are born, you would test them afterwards at the appropriate age. And for RUNX1, as you've heard, the discussions are when is the appropriate age to test children. I think that has to be individualized for each family based on the family history and family wishes, but also whether it would change a child's management specifically as well. Next slide, please. The other option is one could choose to get pregnant, again, either naturally or via assisted conception, and opt for prenatal diagnosis. So this can be done from around 3 months or 11 weeks in pregnancy, where we use an ultrasound guided needle to take a biopsy, usually of the placenta at this gestation, and we extract DNA, and we would test to see if the baby has inherited the familial condition. And usually couples would consider doing this type of testing because if the baby has been found to inherit the condition, they may want to make the difficult decision to end the pregnancy, that they do not necessarily want to pass on the condition. Next slide, please. And then other options we discuss with all couples as well, or all people, is that they may want to consider something like gamete donation, so egg or sperm donation, depending on where the condition is coming from, or even consider not having their own biological children and going down the route of adoption. Next slide, please. And then I think something that is very appealing to many couples or patients is to consider undergoing pre-implantation genetic testing for monogenic disorders. So we call that PGTM for short. So this is a tool that can help us avoid passing on the condition. It also helps couples avoid having to get pregnant, test, and consider ending the pregnancy. So how we perform pre-implantation genetic testing is you have to go through the process of IVF to create embryos. We do genetic testing on the embryos for the familial condition, and essentially we don't transfer back the embryos that have been found to inherit RUNX1 familial platelet disorder in this instance. Now, in the UK, PGTM is available. It is funded by the NHS for couples that are eligible based on certain criteria. However, we're also only able to perform PGTM for conditions that have been approved by the HFEA. So the HFEA are the Human Fertility Embryology Authorization, and they govern all of fertility treatment in the UK, including genetic testing on embryos. And they have a list of approved conditions for PGTM, and how these conditions get approved is considering the seriousness of the condition. So worst case scenario, how significant are the risks for a person living with the condition to manifest themselves within their lifetime. And I think it was about 1.5 years ago where RUNX1 was approved. So it's been added to the list of conditions for which we're legally permitted to perform PGTM. Next slide, please. So PGTM is a wonderful tool. It sounds fantastic, but it is quite a complex process for people or couples to go through. So unlike doing a genetic test on a human where we just need a blood sample, it's actually quite a complex test where we usually need to get family members involved to provide DNA. So what we do is we track genetic markers that are essentially tracking with the familial variant in the family. So because of the complexity of this test, it is not always available for all families, even if the condition, for example, has been approved by the HFEA. Additionally, people or couples will need to go through IVF when perhaps they don't necessarily have underlying fertility issues. And we know not every single IVF cycle is successful. So some couples or people may need more than one round. We may go through the whole process and not have any embryos to transfer because they may all have been found to have inherited the condition. So I've already said that this is available on the NHS for couples that are eligible, but not all couples may be eligible or people may be eligible. So some people may have to self-fund PGTM, and it is very, very expensive. Next slide. I think I'm done. But I just wanted to point out that, there's no right or wrong decision in terms of which route one has to go down with family planning. And really it comes down to, a person or a couple's personal, moral, ethical, religious or cultural beliefs. And these sort of discussions can really be had with your genetic counsellor in the genetics appointment. Thank you.
Thank you so much, Claire. I can see that we've got some questions in the chat. Amanda, did you want me to field those? Do you want to field those?
You are welcome to yeah, go ahead if you feel comfortable. Go ahead. Thank you.
Well, thank you. And please do put more questions in the chat. There's a question about PGTM first. So I wonder whether we do that, even though it's slightly in the wrong order first, just because it comes off the back of your talk yet, Claire. And it's just about if there's been any cases where it's been undertaken for RUNX1 in the UK yet, and whether there were any statistics, or do you want to talk more generally about the statistics of success with PGTM?
Sure, thank you. So I work in a private fertility clinic. Let me just point that out. So obviously there's the NHS PGT centres, which perform, I think, a lot more PGTM cycles than our clinic does specifically. But in my NHS capacity, I have referred on a young patient for PGTM for RUNX1. Specifically, I don't know the outcome of that cycle specifically. I don't have specific numbers related to RUNX1 PGTM cycles specifically, but on average, about 1 in 3 IVF cycles results in a live birth, sorry. But of course, when we're doing the success rates of an IVF cycle depend on many factors: female age, egg quality, sperm quality, and potentially other sort of unknown fertility factors. And additionally, we're testing embryos for a condition where there's a 50% chance to pass it on. So we produce embryos, but then we're halving them because on average, half of them will have inherited the genetic condition. And then again, depending on age and depending on which PGT center you're in, we might also test for chromosome abnormalities afterwards, and that may further reduce the number of embryos available for transfer. So it's complex. There's no one size fits all answer in terms of the success rates for fertility or PGTM. And there's many, many factors that go into it. But on average, we say 1 in 3 cycles ends with a healthy live birth.
Thank you. So there's a couple of questions that are really about what some of my colleagues have talked about in terms of the not having kind of clear standardized guidelines in the UK for care and monitoring. So the first one is that why bone marrow biopsies are not a standard method of monitoring RUNX1 in UK as recommended by the NIH, and then whether there is going to be a UK effort to try and standardize care. If I sort of respond generally, and then Sarah, I might come to you just to answer a little bit about adult pathways. So first of all, there are differences just generally between the US and the UK systems with respect to screening and surveillance guidelines for many, many, many different conditions, including genetic conditions, such as RUNX1 or other tumor predisposition syndromes or even other hematological problems. So we would not usually expect any NIH recommendations to be universally adopted in the UK because of the kind of major differences between the way the two healthcare systems work. Having said that, there are mechanisms by which we could improve standardization of care and develop guidelines in the UK. What we would need is we obviously need the evidence, and the evidence that is, first of all, about the association of like a genetic condition with the associated outcome, and then information about evidence-based things that one can do in order to change outcomes. And I think, as you're all very aware, there's a lot of emerging data coming out at the moment, including some unpublished data. And I think when we held our meeting back in 2022, the feeling was we just didn't have enough of that information yet to be able to really standardize the guidelines. And in terms of that UK effort to standardize it, yes, we are trying to come together more as a community. I think the NICPR, the national register that kind of holds more information, that will allow us to really get more information about the relationship between the genetic information and what's happening with patients in the UK and enable us to develop evidence-based guidelines. But yeah, they don't exist at the moment. So that's a sort of just general answer about the differences between US and UK and the fact that, yes, the infrastructure is developing, but this is a very sort of new condition. And so we're aware that there are still some areas of unmet need. Sarah, did you have any other thoughts?
Well, I completely agree with all of that. And I think that the thing that often causes the difficulty is just that tension that, you know, one guideline that is adopted by one particular healthcare setting is not necessarily going to be appropriate for all. And I think that within the UK and the NHS setting, we really need to see good evidence that things like regular bone marrow examinations are useful in terms of providing something that you want to intervene and make a change about somebody's treatment for, based on just the additional information that you get from the bone marrow. And I think that within the NHS setting at the moment, we don't have that evidence that would point us strongly towards doing that. And so that's why at the moment, the majority of clinicians don't necessarily advise, you know, sort of routinely scheduled bone marrow examinations. That's not to say that bone marrow examinations wouldn't be indicated if there were concerns. So, for example, if there were changes in the blood count, for example, that was causing anybody concern, or new symptoms, for example, then there are plenty of situations in which you know, a bone marrow examination would be performed. But I think we're also very aware that sometimes repeated bone marrow examinations come with their own problems and potential complications, and that it's also very problematic to potentially interpret a bone marrow finding if that is the only thing that's changed. So if the patient is otherwise feeling well, the blood count is stable, but there's some minor change otherwise in the bone marrow, how do you interpret that in you know, in the overall setting? So again, I think with more data and more evidence, we will be able to be clearer about that. But I anticipate that some of that will we're more likely to be able to find consensus about how often we ought to be doing, I don't know, blood count testing or things like that as a first step, perhaps. But it will be interesting to see where that data takes us, but we don't have it at the moment, to be really clear.
Thank you. And I think that's why also we're so glad to be working with our colleagues in America as well, who are doing just this fantastic research and data gathering and have moved this field on, so dramatically. Just before we move off that then, because I can see that there's another question about a recommendation of how often blood counts should be done. And I don't know if you want to respond to that as well, Sarah.
Yeah, sure. So I think it really depends on a conversation between the patient and their hematologist about how often they should have that done. It's really difficult to know. The difficulty with any sort of blood test monitoring that you do in that way is that it's a snapshot in time, isn't it? And so you have a snapshot on that day, and if on that day the blood count looks stable and satisfactory, then everybody is happy to see that. What's really difficult to know is whether if you repeat that in 6 months' time or 12 months' time or not at all, are you going to catch that point at which something might or might not change? And I think that's why in the UK we've been really keen to emphasise the importance of patients reporting any concerns, because actually, if say you had a scenario where a patient was having their blood count monitored every 12 months, there is actually no guarantee that the blood count change will happen just in time for that next blood test. It could happen not at all, in which case the 12-monthly blood test, will still look fine. Or it could happen the next month, in which case if you haven't planned to repeat it for another 12, then you're kind of out of, you're not going to kind of get that useful result. So I think there is no perfect answer to that at the moment. And a lot of places do things differently. We are also aware that lots of patients, particularly as they get older, are having blood test monitoring for other conditions. And that's obviously really separate. And we want to be really clear with patients that if their GP, for example, thinks that they need blood count monitoring for other health conditions, then that should still proceed as per their recommendations. And of course, if alongside that any additional concerns are picked up, then that should come back to the hematology team too. So I'm aware that's a bit of a non-answer, but I think it is incredibly patient specific. And certainly if I saw a blood count in a patient that I was looking after and it showed any features that caused me concern, then the key thing is that I would want to investigate that and potentially repeat it sooner. So that it's more important, I think, you've got that dialogue than necessarily a fixed regime.
Thank you. There's one final question, so please do pop some more in if you would like. And I'm not sure we're going to be able to give really specific answers to this either. So perhaps give a very generic answer, and then again, Sarah, I might come to you. But the question is, what should be the first point of call in a paediatric case if the parent is known as having RUNX1-FPD and the child is presumed to have low platelets? GP, haemophilia clinic, yourselves. So I was going to divide this up. My understanding of this is potentially the parent has been diagnosed, but the child perhaps hasn't undergone predictive testing and it is known about their status, but perhaps is having some symptoms and some features. And just in general terms, in a non-emergency situation, the referral pathway into a specialist is via seeing the GP and asking for a referral to that specialist. And that could be that you could see the GP and say, I'd like my child to have a predictive test for a RUNX1 change that's been found in the family. And that could be usually through clinical genetics, or as Sarah said, could be through the haemophilia centre if they're being managed and counselled by the haemophilia centre. So, or it could be that you're concerned about the child having low platelets and needing further investigations from a haematological perspective. And again, the GP would be the first point of call usually, unless it was an emergency, in which case we have paediatric A&E and routes in through paediatric A&E. If the family was known and it was kind of non-emergency, it may be that the haemophilia clinic that was managing the parent may be aware and may be able to offer informal advice. But again, GP is usually the route in for any child that is not known to a secondary care specialist, because they do the referral and that's how people move through the system. But again, I don't know, Sarah, if you want to comment or if anyone else wants to comment on that.
No, I totally agree. I think the way that I'd interpreted the question was that the child did have a low platelet count, in which case probably the best route of referral is to go to the GP and say, my child has been found to have a low platelet count and we've got this family history. And then the step would typically be, because you've got somebody who's then got a low platelet count is that a hematology clinic would be the right way to go. It may not be a haemophilia centre. It could be, depending on where you are based, then it could be just the haematology department at your local children's hospital or a general paediatrician or something to get that process sort of started. But as Katie says, often if there is a family history, then obviously people quite often know the family within the department, but it's still better, and this happens all the time in my clinic, is that people say, oh, can I, what's going to happen with my son or my niece or whatever, and actually we can kind of sometimes smooth the process, but essentially we still really need a referral coming through from the GP, so that's the best port of call.
Thank you.
I do have a couple. I'm sorry, let me not interrupt. I see there are more written here. I was going to offer a couple of additions, but let's go through these. I'll let you continue. Thanks.
Okay, so there's a question probably for you, Sarah, again. How a TET2 mutation affects the probability of a RUNX1 patient developing a malignancy?
Right, that's a tricky one actually, but a really good question. So TET2 somatic variants are seen in lots of different hematological conditions where we have what we call clonality. So the cells are acquiring new genetic changes, and that can be a sign that perhaps the bone marrow is a little bit unhappy and perhaps slightly more likely to go on to develop problems like MDS and leukemia. But outside of the RUNX1 setting, we know that it's perfectly possible for people to acquire variants in genes like TET2 and not have then necessarily go on to develop any of those problems in the future. There's some work that is coming out of the NIH and places like that that will hopefully help us understand this in a little bit more detail. But at the moment, it's really tricky for us to be able to give a very specific answer to that, because we just don't have the numbers of patients yet that have been diagnosed with RUNX1-FPD and then had the kind of level of somatic genetic testing that we can do on bone marrow and blood samples now, followed over a long enough time to exactly know the answer to that. But that is something that is being actively researched at the moment, and something that I think we will have much better knowledge of in the coming years. But at the moment, this is, I guess, feeds into some of the uncertainty about some of the testing that happens with bone marrows, is that we sometimes get a result that we don't quite know yet at the moment how best to interpret it. But hopefully, as I say, an area that is being looked at really beautifully at the moment, particularly in the NIH.
Thank you. And then there's another question that says, can we assume that if a family has RUNX1-FPD and is being seen by a UK haematologist, that they're in the system and that they would be incorporated into this centralised register, or do we need to reach out to you directly? So I would say, first of all, you absolutely can't assume that they would be definitely in the system and that has been logged. So the way that this new register is working is that families do actually have to be known to a clinical genetics service, because it's the genetic services that are adding people to the centralised register. And as Sarah has said, because historically and appropriately, some of these families have not been traditionally known to genetics, but they have been known predominantly by their haemophilia centres alone, that joining up of information may not have happened. So I think there are a couple of things that we probably could try and do to help facilitate this. So I wonder if, as UK Cancer Genetics Group, we could sort of provide some information about the NICPR to patients that could be provided to the haemophilia centres to give a little bit of information about that. But I think we would also be happy. So what would happen is you'd be added by the clinical genetics centre for which your postcode fell into the region. Bev showed there's sort of 2022 across the UK, and so we could identify by postcode which regional genetic service individuals should be added under. So it sounds like we could do a little bit to support you with that. So I think let's take that offline a little bit. We'll provide perhaps Sarah, sorry, you come in as well. What do you think the best thing?
Well, no, I was just going to add to that many patients with RUNX1-FPD will be registered with the National Haemophilia Database. And I think that's really important, because patients do give consent to join that. And that's a really important repository of data that we've had over the years through patients with bleeding and platelet disorders being seen in haematology clinics. And we are still adding patients to that, because, as I say, the majority of patients are not coming, at least on my patch, are not coming through a clinical genetics or cancer service. So if you have signed up to the NHD, the National Haemophilia Centre database, that is not the same as this. And that's a bit of an area that I know we've discussed, Katie, that it's tricky sometimes to work out how you bring together these different places. So yeah, just coming back to emphasise the same thing, that you can't assume, unfortunately, that you may be in a system, but it may not be quite the same system as what we've just been discussing.
We will take that as an action point from this meeting, because it's a brilliant point that we need to make sure that all of our RUNX1 patients are aligned, and that they are in both systems where they want to be in both systems. So we'll work with Amanda and team and the UK teams to try and make that happen after this meeting.
Great. Wow, what a great discussion. I think we got to everything, didn't we? Or you got to everything. I did nothing. Thank you all. That was such a very and I'm watching the Q&A. If anyone has any last questions. Oh, just someone said Terry's VOS explanation was very helpful. Thank you. I actually texted my team during that explanation and said, going to ask if we can borrow some of this material. It's so clear, and it was really helpful. And I loved that image that I know I need to credit Claire with now, the image of the autosomal dominant pattern.
That's not my image.
Okay, well, it was a great image. Thank you all. It was, I feel like every part of the presentation was very clear, such great explanations, really great discussion. And I think you covered a lot of really good information. And as I mentioned in the chat, we have a private Facebook group for patients all over the world who, if you want to connect, and family members as well, if you want to connect with each other and just sort of discuss challenges and worries. And then also a private WhatsApp chat group that's specific to UK patients and family members. And I'll mention a lot of the questions that were brought up here I've seen across the group. So I'll be sure to sort of summarize what you shared back to them. But with that, oh, and I did want to mention, Bev, I noted, you reminded me about your leaflets you have available and those resources on the UKCGG site. I'll be sure to try to help disseminate that along with what you mentioned, Dr. Snape, about pulling things together and spreading the word about the register, etc. So thank you all so much. And I hope you can enjoy your evening. Glad we found a time that worked for everybody across the world. And these are different time zones. And I look forward to continuing these conversations with you all. Thank you.
And thank you, Amanda. Thank you and your team so much, and for all the work you're doing as well in this area. Really appreciate it. We look forward to working with you again.
Yeah, glad to do it. Looking forward to it. Take care, everyone.